Welcome to Perimenopause and Menopause and everything you want to know. My name is Dinah Grazi. I am fortunately had many years of working in GYN as a nurse for the past number of years. And then when I left there, as you do know, I'm now working in dermatology. I fortunately had the experience of being asked to help with the infertility world. And I've met many beautiful patients over the years in the infertility world, and seeing how much the SBH has availed to helping all these women go through their quest of trying to have a child. So I really thank SBH from the bottom of my heart for helping them. And now we want to advance this to sharing my knowledge. And of course, now we have an expert to talk to us, Dr. Yael Fuchs. So we want to ask her first all about her, because she has a very big background in OBGYN, which she's going to share with you, and many questions that we have about perimenopause, menopause, and postmenopause. So I'm going to turn the screen over to Dr. Fuchs right now.
Thank you, Dinah. Hello, everybody. I am Yael Fuchs. Many of you in Brooklyn know me as Dr. Yael. And for almost 30 years, I've been a general OBGYN. I delivered babies, did surgery, what most of your physicians are doing. And in the last couple of years, I found myself seeing more and more patients who were around the menopause age, maybe because I got there too, and my patients aged with me, but also my colleagues, I found out later, called me the menopause guru. And no guru, just was lucky enough to learn about menopause when we were still using hormones, when we weren't scared of them, and therefore knew more than some of the doctors that came out after me because they were just not trained on it. And a little background about it: in 2003, there was a study called the WHI study, the Women's Health Initiative, that actually was looking at women on what's called Prempro, which was the original hormone we used, which was an estrogen and a progesterone, and actually was supposed to compare it to women on estrogen only, those women who didn't need the progesterone because they had a history of hysterectomy. When the initial data came out on the Prempro part, it scared everybody, and literally the world stopped using hormones. It showed a slight increased risk of breast cancer, slight increased risk of stroke, increased cardiac, and scared everybody away. I was from the generation that wasn't as scared because we knew a little bit about it. And luckily, people kept on looking. And in 2004, the estrogen only arm, the Premarin only arm came out. And what we learned years later, and now that's why a lot of us are talking about hormones again, and you're hearing more about menopause, because what we found is if we only use the Premarin, and in the right age group, the original age group were 60 to 75-year-olds, so women who haven't seen hormones in their bodies for a long time. And what we realized that if we use hormones in the younger age group, or in women up to 10 years past menopause, we actually saw a protective effect for breast cancer, a protective effect for cardiac disease, and we are feeling much safer now. And what we learned from all of this was that the progesterone we were using was the wrong one. Unfortunately, as I said, that caused 20 years of doctors in training and GYNs who never used hormones, knew nothing about it. And that's how I became the guru, because I knew about it and I continued researching. There are a couple of societies, what was called NAMS, it's now the Menopausal Society, and also ISHWISH, which is the International Society for the Study of Women's Sexual Health. that I belong to, and I've always been interested. So no guru, just interested. So let's start with, I think the first question that Dinah originally asked me was, and most of my patients ask me, is what is menopause? Because when do we become menopausal? What is postmenopause? What is perimenopause or premenopause? So let's start with just a few short definitions. Menopause is very simple. Once you haven't had a period for a full year, you are called, we say you hit menopause. And anytime after that, for the rest of your life, you'll be considered postmenopausal. Before we hit menopause, though, while we're still having our periods, a lot of us start having symptoms due to decrease in our estrogen supply, and that is really what causes most of our problems. And premenopause or perimenopause actually could be for 7 to 10 years before we hit menopause. And one of the first questions I get from patients is, oh my God, I'm still getting my periods, but I feel like the stuff my mother used to tell me. So yes, that is perimenopause. And most of our symptoms, as I said, are from decreased estrogen supplies. The first symptom that most people know about and feel is hot flashes, but we get a lot of other things. We get mood swings, we get anxiety, we get palpitations, we get joint pain, we get brain fog, the most popular one for most of us. We have dry skin, we have hair loss, we have problems sleeping. Our weight changes even though we are eating less and working out more. We start having pain and vaginal discomforts, which could be pain, which could be itching, which could be dryness. So all these symptoms are all from decreased estrogen production in our body. And as I said, long before it's menopause, it's perimenopause and premenopause. And these are the symptoms that we associate with menopausal symptoms, with perimenopause, and these can happen at any point of our lives. In general, the average age of menopause in the United States is 51. Most women go through menopause between 45 and 55, but from 40 to 60 is considered normal. So if any of you are thinking that, oh my God, this can't be yet, or doesn't mean it is, but from 40 to 60, it is normal. But because things can happen 7 to 10 years before, you could be in your 30s and start feeling these symptoms. It's all normal. I am going to go slow. So if I see we have questions here. If any of you guys want me to slow down and you have questions. Yes.
I just want to answer some of the questions. One question is it going to be recorded? Yes, it's going to be recorded so you can watch it again. There's a lot of information that Dr. Fuchs is going over. We went through over a big list of what we think that really you need to know. One of the questions is, so you talked a little bit about what the different menopause situation is: perimenopause, menopause, and postmenopause. But what does it actually do to your body? Like when you have a lack of estrogen, how does it affect you? What happens there?
So most of the symptoms I mentioned are what happens. We have estrogen receptors in a lot of areas in our body, and that's why we're having these symptoms. So all those symptoms I described are actually what's happening. Most of us don't discuss these things. A lot of doctors don't ask the questions because unfortunately a lot of doctors don't have time, but these are the original questions really that we have to start with. Are you having any sleeping issues? Are hot flashes waking you up in the middle of the night? Have you been having drier skin, hair loss? Is intimacy getting more difficult with your partner because of lack of estrogen? Those are the symptoms, and that's what lack of estrogen actually causes.
And the lack of estrogen, how does that affect your bones?
Well, obviously, once we go through menopause, it does also increase the risk of decreases our bone density. And that is one of the things we used to put people on immediately on menopause. once we go through menopause, we started estrogen, and one of the reasons, the big reasons, was for bone loss. And as I said, because of this one study, everybody stopped using it. But yeah, it is wonderful to help to protect our bones.
Okay.
I see somebody ask the question, if I may, about the brain fog. Does it last forever? Each one of us is different. So sometimes, part of the brain fog is a lot of the symptoms have to do with the change. Our body's going almost through withdrawal from the estrogen, but a lot of it actually does continue. And, we can reverse things if we use hormones. So we can reverse things, but part of it has to do with just the initial change in our body and our body responding to the changes. And other things have to do with the continuous lack of estrogen. So going on hormones, and we'll discuss that in a little bit, can help with a lot of the symptoms. And some people believe that you should be on it forever to continue protecting your bones, to help. Somebody asked here about Alzheimer. We know that it helps with dementia. We also know that it helps, as you said, with the bone. So if I stop taking the hormones, obviously the bone density will decrease again, just like if we stop using any of the osteoporotic medications. They help while we're on it, but we will reverse while we stop it.
And there's always questions about bioidentical hormones. How would you answer that?
Well, the first thing we need to understand is bioidentical hormones. Our hormones, what we call bioidentical, is just the hormones that we take, meaning produced from any source, if it's FDA approved pharmaceutical or from compounding pharmacies, they are all bioidentical, meaning they're identical to the hormones our body naturally makes. A lot of people think that when we say bioidentical hormones, we mean plant-based hormones, a lot of people call the naturally produced hormones. But those are, when we talk about the plant-based, we're talking about bioidentical compounded hormones versus bioidentical. So bioidentical just means identical to what our body makes.
Okay, thank you so much.
Mm-hmm.
So some of the other areas that we discussed is taking the medication. Let's say somebody decides to take the medication, and the advantages are, obviously, you mentioned about protection of your heart, your brain, and what are some of the other areas like that would be positive for all of us?
So in general, and this talk is not just about hormones, it's about everything that has to do with menopause. There are a lot of symptoms that we have different things we can use for, but hormones in general, since you brought them up, are the only way to help with, and systemic hormones, I should say, are the only way that we can help with all the symptoms. So if I want something that's going to help with my brain fog, going to help with my hot flashes, going to help me sleep better, going to help me my hair loss, going to help me with all the dry skin. Systemic, meaning as it goes through my bloodstream, through my body, that is the only thing that's going to take care of all these symptoms. And systemic hormones come in multiple forms. We can take it orally as a pill, and that today we're more prone to give, more doctors will lean towards using what we call the transdermal, either a patch, a gel, a spray. The Ava Mist is a spray. And the reason for that, when we don't take medication by mouth, we skip what's called the first pass effect. The first pass effect is when it goes through the liver, and just like when we take birth control, we're told to, if we're taking antibiotics, have some backup, because if more than one medication that is broken down by the liver passes through the liver at the same time, one affects the other. So by doing the transdermal, we skip that first pass effect, which gives us some protection.
Thank you.
Using a systemic form will help us with all the symptoms. Some people don't have all the symptoms or do not want to take systemic hormones. And for patients who only have issues with intimacy, with vaginal dryness, itching, discomfort, and just want something local, There's estrogen that's creams that we use vaginally, and actually those are minimally absorbed, so minimally that we don't have to do a progesterone along with it, even in patients with uteruses. And actually working with some oncologists, I've even had some of my breast cancer patients on vaginal estrogen because the absorption is so minimal, below the level of what we call significant. So that is one of the things that if someone wants just something locally. There are things that we do for some of the other symptoms. A lot of patients complain of anxiety, mood disorders long before they go through menopause and then after menopause because of the lack of estrogen. And if that is your only complaint, we use things like SSRIs. Most of us know them as the most common one that we use for hot flashes is Effexor. We started using it for the anxiety and the mood swings, and we found out it helps for the hot flashes. Uh, Zoloft, Prozac, Paxil, they actually also help for hot flashes. For patients who don't want those meds, gabapentin, which is used for pain, helps with the hot flashes, but not with the anxiety and the mood disorders. So depending on our symptoms, we will use different things. And, again, hormone systemically will help with everything, but not everybody wants that.
So we're having a question about if there is breast cancer in the family history, would you still recommend hormones?
So obviously, we have to take a very good history, and that's the most important thing. If someone is BRCA positive, we do not use hormone therapy. But if there's no BRCA in the family and there's just a family history of breast, then the answer is absolutely. And remember what I said, that we had learned from the estrogen only arm that we actually, in the right patient population, meaning starting it right as we go through menopause, starting it up to 10 years past from menopause, we actually saw protective effect from the estrogen. So a lot of doctors aren't comfortable because they do not know the data. A lot of doctors just don't know and have never dealt with it and don't give anything because of fear of the unknown. But the studies, which is the most important thing, have shown a protective effect. And actually, in the olden days, I had patients that we actually said, even if you had breast cancer, studies had shown that if you take hormones and you get a recurrence, the recurrence was less aggressive, more curable. So there was a time when we actually really felt it was protective and we didn't fear breast cancer. Today, we are not as gutsy, shall I say, but we do have a protective effect. So, but we have to take the proper history, and that's the most important thing, knowing about family history, knowing personal history, and that's something that we have to, take each patient.
So I recently had a patient who had something called lichen sclerosis, and she was having a lot of so she came to the dermatologist for this, and now she's being treated by gynecologists as well as dermatologists. Can you explain to us what that means, please?
Well, lichen sclerosis is actually an autoimmune disorder of the skin, most commonly seen in the vulvar area. And in the olden days, we thought it was only in the menopausal patient, and that's because the lack of estrogen actually just makes it worse. We see it in all age groups. I have patients, my youngest is age 16, so we see it in all patients. Sometimes it gets stimulated after pregnancy. Sometimes we see it only once people go through menopause because of the lack of estrogen. It is not a menopausal issue, but it is seen more once we go through menopause. But in general, it's an autoimmune disease affecting the skin, very common in the vulva area. And the reason I actually end up seeing a lot of those patients is because they come to me for pain with intercourse or inability to have intercourse, thinking it's only hormonal, and then we make a diagnosis of lichen sclerosis also. So, but that is not necessarily menopause.
And someone had asked me about something called the Mona Lisa. Can you please explain what that's for?
Okay. The Mona Lisa is actually a laser procedure. I am sure most of you have heard at least or have done facial dermablation. It's a laser procedure that helps to stimulate collagen and blood supply. And we do it for the vaginal tissue to help with the vaginal dryness. So for patients who don't want to constantly be using the vaginal creams, for people who don't want to do hormones, they've tried lubricants and moisturizers, and they're just getting fed up. You know, it's a great solution. It's a simple office procedure. I actually do it. So, a lot of GYNs know about it. Very few do it. Again, because of lack of education and knowledge. It's not one of the things. There's so much to cover when we are residents and we get educated that unless you go to investigate more and learn more, we don't find out about it. But it's, again, it's doing a facial dermablation vaginally. It's 3 sessions, painless, and makes a very big difference.
Okay.
And actually, for one of the side effects we found, I like adding this one if I'm already mentioning it, is one of the side effects, it was intended originally for helping rejuvenate the vaginal tissue, but we found that it actually helps women who have stress incontinence, losing urine when you sneeze, when you cough, people who don't want to have surgery and do the sling or some of the surgical procedures. We've had great success. None of this
Wow,
is permanent. It's something that you have to get touch-ups once a year, but works amazingly.
wow, that sounds very, very interesting. Thank you. We have a question of what is the correlation between mRNA uh, and osteoporosis?
Of
M
mRNA,
between mRNA pause and osteoporosis. Not sure what that means.
I'm
The only thing I could think of is what is the correlation between? Could whoever asked the question, can you elaborate on what it's pertaining to? The only thing I was thinking of is something to do with osteoporosis and the different treatments that are availed for osteoporosis. I'm not sure. Just for my rheumatology part of my life, and the different drugs that are out there, but I'm not sure what they're asking.
sorry, not one of the things I know
Yeah.
well, so I apologize for anybody who has that question, whoever had the question.
We answered the question about the Alzheimer's and dementia with menopause and the hormones helping. And I don't see any more. Oh, wait. We asked about the cancer. One of the other things that we were talking about, I don't know if you mentioned about the compounding pharmacies and
Mhm.
what they do. And
So compounding hormones are actually for patients who prefer plant-based hormones. We can compound combinations of estrogen, progesterone. We also use testosterone for different reasons. Some people want to do plant-based hormones. So they do the same gels, and for transdermal, they do suppositories for vaginal. And the one thing that doesn't come in a regular FDA approved pharmaceutical is an estrogen testosterone, which actually is great for what we call vestibulitis. And for vestibular, we have a lot of testosterone receptors, which actually help with libido also. And so we compound estrogen and testosterone to use for local hormones.
so I have a client asking, do you accept patients and can you share your info? Their doctor is not really recommending hormones.
Um,
And
okay.
how do we know how much or what to take?
Okay, so first of all, by the way, as far as how much and what to take, we go, you know, a lot of doctors say let's do your hormone levels, but hormone levels are more just to know a baseline. You know, I usually treat patients by their symptoms. We start with the lowest doses and work our way up to what's comfortable and what we can. As far as sharing my information, I didn't realize, I'm not sure, are we supposed to be doing that? But my name is Dr. Yael Fuchs. My practice is adaptive gynecology, and I started it 2 years ago when I transitioned to basically focusing on menopause, or basically helping women adapt through the different phases of life. That's how I got to that name. I see the younger teenagers, actually some that I delivered, and as they're going through different phases of their lives, but helping us all adapt to this new phase of menopause, perimenopause, etc., or post-reproductive age, that a lot of changes happen in our body. Yeah.
Can I ask you, what questions should the patients be aware of when they're going through the phases of perimenopause and menopause? What should they be asking themselves and then possibly asking their doctors or searching?
Well, absolutely. So, you know, as we go through the perimenopause, a lot of us go through a lot of different symptoms, changes in our body, from mood, from physical, from, and I think the most important thing is to discuss these things with the doctor. You know, if I can use myself as an example, I'm usually don't like doing it, but this is one thing I'm willing to admit. I'm asthmatic, and as I was going through menopause, every time I had what I thought was a hot flash, most probably I had chest tightness. So I called my buddy and I said, "Hey, Dave, this is what's going on." And you know, we did a stress test, we did an EKG, we did an echo, we did a full cardiac workup. So a lot of the systemic symptoms we're feeling could be another medical problem. So first we rule out everything and make sure it's nothing else. And we can literally blame almost every symptom on perimenopause, decrease in estrogen in our body. And as I said, I had chest tightness every time it was a hot flash. So because I'm asthmatic.
Wow.
So, but you know, there's a lot of things to discuss with our doctors. We usually, if you mentioned bone density before, we know that the highest bone loss actually starts in the first 3 years of menopause or decreased estrogen. So, you know, one question to ask your PCP or your GYN would be, when should I start my first bone? When should I get my first bone density? In the olden days, we started once you started becoming perimenopausal, when you were having significant symptoms telling us that your body's having less estrogen in it. And then we used to do it every 2 years. Studies have changed and the recommendations have changed. If you take steroids because you're asthmatic, if you have thyroid disease, you know, the answers will be different. So it's very important to ask your doctor, when do I need to do my first bone density? If somebody has anxiety, you know, it could be from personal other issues, it could be from menopausal changes. So it's something to talk to your internist about, it's something to talk to your GYN about. So it really is about talking about your symptoms. You know, we have a tendency to just say, oh, I could deal with it. Or, you know, our mothers and grandmothers said, oh, just deal with it, or we ignored it. Don't ignore it. There's no reason to. You know, we have answers to a lot of things. We have options for a lot of things, and it doesn't have to be hormones. But, you know, if we don't discuss or we don't ask, nobody's going to know. Part of the reason I switched from doing general OBGYN and focusing on this is these days, you know, you have very minimal time to spend with patients, unfortunately. And so a lot of doctors don't go through all the questions. So bring it up. You know, patients should bring it up so we can address your issues. And
So I have a pretty interesting question, and I'm sure the people will can relate to it. She's saying that I was taken off birth control because of an aura of migraine and the increased risk for strokes. Would this hold true with hormone replacement as well?
So the answer to that is yes and no. Obviously, vaginal estrogen doesn't absorb systemically, well, minimal. You won't have any issues with that at all. Um, you'll have less with transdermal than with the oral. And the question also is there any other risk of strokes in the family, etc.? Many people get are they cyclic
They
migraines? Or are
they didn't, yeah, they didn't
okay.
say what kind of
Well,
migraines.
whoever asked the question and is listening to the answer, we ask more questions and to really associate it. Is it a hormonal thing? Is it happening every month with your cycles, with your periods, or is it not a hormonal thing? So we
Well,
could do
she was on a birth control,
right.
so
She was taken off. The risk of birth control actually is a little bit higher than with the risk. We actually prefer having patients. A lot of doctors leave people as they go through menopause on birth control instead of putting them on hormone replacement. And actually, the hormones of hormone replacement are felt to be safer than the birth control.
right.
So, yes.
Okay, and someone's asking, are hormones covered by insurance?
Well, that's a hard question to answer because even in the same insurance, from the same insurance company, there's about 1,000 policies. So most of my patients I've written the regular pharmaceutical FDA approved, get from your pharmacy kind of hormones. Um, they've either had it 100% or their copay, and depends on your insurance, which tier. Therefore, we use a lot of the generic, would give transdermal estradiol versus the brand names. But the compounded isn't, but
That's what I was
most
going to
of
say.
the regular FDA approved from your pharmacy is covered. Depends on your plan.
Okay, so at 63, my body put on over 10 pounds. My bust size went from an ABC cup to a double D. Is that common, I guess?
So when we don't have estrogen, it's very interesting because what studies have shown is that once we're menopausal, we have more what we call visceral fat. So we actually increase our visceral fat. Some of the studies I've read say we go from a 7% to a 23% of fat. Viscera are our internal organs. And that's why a lot of women also complain that when they go through menopause, they have this upper abdomen, the wheel around their belly, because the fat comes in different areas, the distribution. A lot of that is because estrogen functions as an anti-inflammatory, and when we increase the fat, the visceral fat, that causes more inflammation. So it's very common, and basically we have to, in those situations, I highly recommend the anti-inflammatory diets. Increase your fiber. We actually, for inflammation purposes, we want at least 25 grams of fiber a day. The average person eats about 10 grams a day. You know, we prefer getting your food, your nutrients and your fiber and your vitamins from food, and it's just about changing our diets versus not eating. Not smart not to eat, it's just changing how we eat. But very common, yes. It is menopausal symptoms. Menopause
Okay,
related.
thank you. And then somebody's asking about that bone densities. Are they covered unless you're in true? So will insurance companies won't pay for a bone density unless you're in menopause? Is that the case?
Well, if you're in perimenopause, if you're having menopausal symptoms, then by definition, you're starting to have less estrogen, and the answer is they will cover.
But
And again, I hate to say it, but when we're talking about insurance, every insurance is different. So I can't tell anybody, yes, your insurance will cover something, because that is very broad. And nowadays, insurances are looking for any reason not to cover something. But if it's not a routine bone density, it's you're having menopausal symptoms and therefore bone density.
Right. I think everyone's an individual in the sense, correct? In terms of if they have family history and they also appear to have issues with bone loss. Would that
Absolutely.
that
And
would
it
help?
depends on other medication also. If you're on steroids, if you were
Correct.
asthmatic and you had a long-term use of steroids, if you have thyroid disease, all those have an effect also. So there's a lot of times we do bone densities in much younger age groups. I want to answer, actually, I just noticed one of the questions, what's the age limit to take HRT? Sorry, I don't know. Dinah is focusing on the questions. I'm just focusing on talking, but I noticed this question. So from the latest studies, and I'm going to say two different things. The latest studies that we looked at, and the results we saw from the estrogen-only arm, the recommendations in general are start immediately with menopause, up to age 60, not more than 5 years. But most of us physicians who work with menopause, most of the people who do the research with menopause, if you go onto the Medical Society, Menopausal Society on ISHWISH, most of us docs who have been doing hormones. I have two patients at 86 who are still on hormones. One is only on the vaginal, and the reason for the vaginal is actually, you can say it's life-saving, because as we age, we get more UTIs and you can get sepsis. A lot of elderly die from sepsis from UTIs. And one of the big things about menopause is we find that women get much more urine infections due to lack of estrogen. So using local vaginal estrogen has helped to prevent UTIs. So one of my elderly patients is on it because she used to get UTIs all the time. And once I started her on the estrogen, she hasn't had another UTI since. So we are 26 years later, and I'm still writing her East ring. It's a vaginal ring that you put in and change every 3 months. And, I think it's life-saving. So vaginal estrogen for sure you can do till as long as you're on this earth, or to prevent UTIs and hopefully for other things too. Systemic, again, the transdermal, I have patients much older than 60 who are still taking it because they feel good on it. Obviously, they see me twice a year. Their pressure has to be fine. We have to update our, medical history and see if anything's changed. Not everybody, not every physician. And as I gave you first the criteria originally, up to age 60, but a lot of us physicians who do menopause, who do hormones, are very comfortable with using it for longer. Always in the right situation with the right patients. Take every patient as an individual.
Thank you. Now, both hormonal and other types, I guess, of medication. I'm not sure. Maybe birth control, and how it affects migraines. I'm not sure of what they're looking for, but that's how I kind of took it.
So hormones in general, and actually in the olden days, just I'm veering off a little bit to the side. We used to say anybody who's hypertensive, we don't let them be on hormones because there's a slight increased risk of blood clots, strokes. The reality is actually that estrogen is a vasodilator.
Right.
And as a vasodilator, if you have a well-controlled hypertension, again, the physicians who do a lot of hormones, who work with menopause and are comfortable, have no problem giving a well-controlled, stable hypertensive. We have no problem using hormones. On the other hand, not in someone who's unstable. Now, migraines are actually vascular headaches, and the medication that we use, we want to vasoconstrict, we want to decrease the blood flow to the brain because that's what causes the headaches. So, an estrogen hormones, technically as vasodilators, do increase the blood flow a little bit, and that's why some people do get a little more migraines if they're prone to migraines. I'm not sure if I answered that question.
Well, you did, but I have a question about that.
Mhm.
What somebody who's going in to the period of having lower estrogen, would that affect and cause them headaches?
There's a lot of different types of headaches. So are we talking about migraine headaches or other headaches? And
Right.
again, it's a complex question. Headaches isn't one of our most common symptom patients complain about, but I do have one patient who insisted that it was all about lack of hormones, and we tried the hormones and she felt much better.
Right.
Now, sometimes is it the hormones or is it she's happy she has her hormones? Placebo effect, but it's not one of the common symptoms or causes. But as I say, anything goes, but we have to see the right patient and do the right thing. But not one of the most common symptoms
Right.
of menopause
I
and
think,
reason to use hormones.
thank you. I think you answered that somebody, I'm not sure if she heard, do you do the hormones cause unwanted side effects?
So most patients do wonderfully on hormones, and it really just, they all either get better with the hormones or don't. And when they don't get better with the hormones, and as I said, I usually like to investigate the symptoms before I start the hormones, make sure it's nothing else.
Right.
The slight increased risk of strokes was, as I mentioned about the study, the WHI study, when we looked at the estrogen only arm, we saw the protective effect on breast, we saw protective effect of cardiac, but we saw less strokes than we saw in the estrogen progesterone arm, but no strokes. So can there be anything? Again, that's where we have to choose patients properly, because if you have a strong family history of clotting, if you have a family history of people of strokes or or blood clots of any kind, DVTs, thrombophlebitis at young age, before I start anybody, and even my young patients on birth control, if I get a history like that, we test them for what's called the thrombophilia workup to make sure they don't have a genetic predisposition to clotting, because most people who do get strokes while on hormones are actually genetically predisposed to clots. So again, taking the proper history and choosing the right patients to put on hormones is a big factor.
Thank you. So
I see. Can I just answer this one question that I just noticed here? Can hormones be started years after menopause started, 5 to 10 years later? So the answer is yes. We say up to 10 years past menopause. So if you're 5 to 10 years, yes. And again, also depends on the age and the rest of your and other medical problems. Obviously, if you're in your 70s, I prefer not. If you're in your late 50s, obviously not even a question. If you're in your early 60s, I would be talking to the patient. Again, according by the criteria, again, up to 10 years past menopause, and don't start past age 60. But I don't, to me, every patient is an individual. But 5 to 10 years after menopause, you're still in the range where we may start hormones, yes.
okay, and is
And
menopause?
again, sorry,
Sorry.
and sorry, Dinah, and don't forget, we're talking about systemic hormones, vaginal hormones. Everybody at any point, you can be 90, I'll start you on it.
Okay, so that means somebody who's having recurrent urinary infections is a candidate.
Absolutely, a
Okay.
very good candidate.
Good.
And even the general urologists know that. So it's not only
Right.
the gynecologists.
Okay. Now, the question is menopause connected to joint back pain.
Absolutely.
And can hormones be effective?
Absolutely. One of the symptoms is joint pain from lower back, from all joints. Obviously, you want to make sure it's not arthritic. You want arthritic, like a rheumatoid arthritis. You want to make sure it's not from the autoimmune diseases, but lack of hormones, menopause, do increase joint pain, and systemic hormones do help.
Okay.
And again, the thing I keep on saying, rule out everything else before you blame menopause, but absolutely.
Thank you. Thank you. Those were great. I think we covered almost all the questions. If I didn't see one, can someone please write it again? I might have missed. I think we went over. So I can actually tell you a little story so I worked many years in infertility and GYN. The doctor that I worked with was first mostly infertility, and then we started taking GYN when when she went into a private practice. And I learned a lot about it. And in my era, I worked very similar to Dr. Fuchs of advocating taking hormones. But we were the very few doctors in the time of the 90s that was advocating hormones. And one of my patients had a biopsy done, and she actually left, and she came back and she says, "I have a question for the doctor." And at that point, the doctor was in the room with another patient, and I said, "I'll ask her and I'll give you a call back." And her question was, well, since she had a biopsy, she wanted to know when she could have relations again. And here's the woman who's on hormones and in her 80s. And I answered her question because I did know the answer. And I then went back to the doctor and said, well, now we're nowhere near that age. But when I get to that age, that's how I want to be treated. And have the thought process of feeling young forever, because that's what she was. She was feeling young and vibrant and good.
That's wonderful.
Yeah, it
Thank
was
you for
very
sharing
sweet. It was a
that.
very, very sweet story. And I'm sure you had many stories.
Absolutely. I could write books, but I wouldn't. I won't. I see a question here about what tests should be done to check if you're perimenopausal. The truth is, a lot of doctors, since they don't know what to do, will say, let's check your hormones. But as long as you're still having periods, even if they're not every month and they're every 2 or 3 months, obviously if you had clockwork monthly periods and now they're 2 to 3 months apart, you're perimenopause. But even if you're having regular periods, but you're having hot flashes, you're having new anxiety, new mood swings, difficulty sleeping, it's a possibility. So obviously, we rule out other causes, but that's why I say we work with symptoms, not with labs and numbers, because as long as you're going to still have periods, we look at LH and at FSH will still be normal. Estradiol sometimes could be lower if we get you at the right time of the cycle. That's also part of the fertility workup when people have fertility issues. But you still can have normal labs. So if you have symptoms, then we talk about hormones once we rule out everything else.
Right.
There was also a question I heard I saw there about hair loss, if I may.
That was my,
yeah.
that was maybe.
Decreased hormones. As we go through menopause and we have less estrogen, we do lose our hair thins out, and yes, systemic hormones will help. But also, one has to always check the thyroid, because abnormal thyroid, hypothyroidism can cause hair loss. And other than seeing a GYN who does the hormonal workup and everything else, some people actually go to the dermatologist for a scalp biopsy, because and that's more when you have alopecia than when you just have more thinning hair. But Dana, you can, I guess, talk about the derm stuff more than me. But absolutely, menopause, decreased estrogen does cause hair loss, thinning hair.
Right. Well, there's different, it depends on where the loss of the hair, similar to a male losing your hair in that area. I don't want to take the place of a dermatologist, but it all depends. I mean, if you have a circle that is similar to an alopecia where there's actually a lack of hair in that area, there's many treatments for that. So I will give a boost out to dermatologists because there's so much on the cuff for treatment for that. And please don't suffer with something like that and feel, unhappy about it, because we all want our hair similar to what it looks like, whether you're wearing a sheitel or not. And if you have hair, then you want to look and feel good. I have a question about can hypothyroidism bring on perimenopause sooner?
So hypothyroidism, hypo and hyper, will affect your hormones and your cycles. So when we have fertility issues in the younger non-menopausal patient, but in the younger population, one of the first things we look at is thyroid. So if you have a thyroid issue, reversing your thyroid, as in treating the hypo or hyperthyroidism, actually both can cause issues with cycles, will actually correct your cycle. So it's not going to cause you to have menopause earlier. It's not going to. What is menopause? When we're born with the maximum eggs we'll ever have, and once our ovaries finish producing eggs, producing follicles, that's when we go through menopause. The thyroid affects our cycles that are associated, but they are not affecting the ovary itself. So if you're having changes with your cycles and your thyroid is off, correcting your thyroid should correct the cycles.
Right. Thank you. That's a very important issue, and it should be checked.
Mm-hmm.
So the question is, my rheumatologist gave me HRT at 66. I had all the side effects that was written on it, but my gynecologist was totally against it and stopped after 1 month on it.
Okay, so again, that goes to the criteria of up to 10 years past menopause, not past 60. And again, if you were started on hormones at a younger age and continued, it wouldn't, I'm comfortable with continuing even at 66, but starting you at 66 is a little bit, you're a little bit past the age where most of us are comfortable starting hormones. What were the you said you had all the symptoms. You were having all the menopausal symptoms, or you were having side effects?
It had all side effects that was written on, I guess, the paper, the insert,
Right.
which is a very common, I mean, all the inserts are written, all side effects. Dr. Fuchs can go over that, but anything is written to protect their company. Right. Go ahead. I'm sorry.
Okay. So side effects, when we first start on hormones, a lot of women, and systemic, not the vaginal, but the systemic hormones, the oral or transdermal, we feel pretty much the same symptoms we feel right before our periods, actually after ovulation, the breast tenderness, the breast fullness. Some people will have a little spotting, your body's reaction to starting the hormones, but that should go away once your body adjusts to having the hormones again. And because we're not cycling your hormones like with our cycles, but you're on continuous estrogen, progesterone constantly, or estrogen only if you don't have a uterus, then those symptoms will go away. Spotting should go away, and breast tenderness. Now, if there's any question, many times I will do a sonogram on a patient in the office or send them for a sonogram before I start them on hormones, just to make sure there's nothing going on, no underlying pathology that's there. Once you're on hormones, you don't need it to do yearly sonograms. That's the old school. But I usually get a sonogram before, and many times I'll do it in the office, or I'll send a patient to the radiologist to do it. and only if there's any abnormal bleeding. So when you first start, I expect it and I wait for your body to adjust. If you're on hormones and have bleeding later on, when you haven't had any hormones, then of course that needs to be investigated.
Okay, thank you. I see a question about, do you recommend supplements to help with perimenopausal symptoms?
So, I like getting everything from the diet, but when patients start having hot flashes and things that work well, St. John's wort helps. Something called Estrovent. Estrovent is a combination of black cohosh and soy, or just some people just recommend black cohosh alone. That helps a lot with the symptoms. Um, Obviously, if this is not about symptoms, but calcium, vitamin D, once we're not producing as much, if we're perimenopausal, not producing as much hormones, we recommend every woman to be on calcium, vitamin D to protect the bones from osteoporosis. So but for the symptoms themselves, soy, black cohosh, and um, eating soy, and this is one thing that's very important for people to know because a lot of people fear soy because of breast cancer. It's if you eat soy, edamame, tofu, that kind of soy, you will not increase your risk of breast cancer, even with a family history of breast cancer. The soy is known as a phytoestrogen. It stimulates the same receptors as estrogen, but it is safe. On the other hand, soy pills, so Estrovent or soy pills, is one of those things that actually most physicians tell their patients to keep away from if there's a very strong history of breast cancer, because that is very different than the natural soy in the food. So eat
Thank
tofu and
you.
edamame versus taking soy.
Okay, thank you. Does the HRT cause weight gain?
Again, whenever we start hormones, some of us will gain some weight from water retention, just like when people start using protein shakes, etc., until your body adjusts to it. But it's not weight, it's not fat gain, it is water weight, and then your body will adjust.
Right.
But that is rare. Remember that one of the things, the weight gain associated with lack of estrogen is increase in visceral fat. So when you do hormones, when you're taking estrogen, actually you're decreasing that.
Okay, thank you. Is there any way to postpone menopause? I can't wait
Unfortunately,
to get.
I know. And I actually saw that question, and hello to the question asker. No, it does not. Hormones will not, there's no way to postpone menopause. Once your ovaries use up, once all your eggs are used up, we're born with the max, and once they're used up, that's it. We're done. So not really.
Okay, thank you. You know what? It's kind of getting late. I'd like to know if Dr. Fuchs would join us again if we need to have it by demand, and we can then continue with more questions. But I really thank everyone for coming and joining us and making it a wonderful evening.
It was a pleasure. Thank you for listening to me. This is my first, I'm from the older generation. I've never done an Instagram kind of a thing, but thank you for tolerating my lack of, I'm sitting here holding a phone for the last hour. So hopefully I didn't shake too much. My sister always says I move the phone too much and she gets seasick. But with pleasure, this was a pleasure, and thank you for inviting me.
And
And
I want to thank Ethan Todd for helping us with all of our glitches and making